Hi, everyone. Thank you for joining us today for a discussion on preventing opioid misuse through pain coaching. I'm Alicia Violet. I'm a graduate research assistant at the Injury Prevention Research Center at Emory, or iPrice. iPrice supports research, education, and outreach for the purpose of reducing injury and the burden of injury in Georgia and the Southeast. Today, I'm joined by Mary Can from the Georgia Public Health Association Emory chapter, who will be helping me to facilitate this conversation. We are also joined by Lauren Kirk and Bailey Burrell, who are both life care specialists with Christopher Wolf Crusade, who will be telling us a little bit about the work that they do. If time permits, we will take audience questions at the end. You can submit questions that you have through the comments. So to begin with, Lauren and Bailey, how did the life care specialist position get started?
So the Life Care Specialist program was developed by Christopher Wolf Crusade, which is a nonprofit that focuses on prevention for the opioid epidemic. Our founder, Cami Wolf Rice, lost her son to a drug overdose in 2016. His death was a result of becoming addicted to pain medications due to multiple surgeries. Life Care Specialists create a protective barrier between safe opioid usage and misuse. And our flagship program is at Grady Memorial Hospital, but our mission is to expand this program to other hospitals all around the country.
Awesome. Yeah, thank you for that overview. So child life specialists are often utilized in a pediatric hospital setting. Can you give us an overview of some of the activities you do as life care specialists and explain how this is similar to or different from the work of child life specialists?
Yeah, so some of the techniques we use are very similar, such as distraction materials, but the real focus of life care specialists is to prevent a patient from becoming addicted to opioid pain medications. So we discuss with our patients what type of opioid they're taking. We talk about what Narcan is, how to use it, why it's so important. And we really try to set the expectation that opioid medications are for the short term. They're not a permanent fix. To that degree, we help them create their own pain management plan and set their own goals. But we really want our patients to be well without the risk of becoming addicted to their pain medications.
Yeah, that sounds like really interesting work.
Yes, I agree. So I have the next question. How does this pain management strategy differ among other pain management strategies? What makes this approach novel?
So predominantly the conversation around pain management involves cutting edge plant-based pharmaceuticals, nerve blocking, Vibracool, like very technology and pharmaceutical focused interventions. And these are great cutting edge innovations in pain management, but none of them are behavioral. And so very few people are treating on the behavioral side of pain. And almost no one is teaching behavioral techniques and addressing all of the social determinants and comorbidities, especially that we experience in our patient population at Grady. And so originally the LCS position was strictly wellness skills and opioid education. And naturally it has evolved into kind of a hub and spoke model. Our physicians and nurses that we work with kind of pass the baton to our team to teach the opioid education and wellness skills. And then we can pass along to existing hospital services like food as medicine or addiction medicine. And these are services that our patients need and qualify for, but would not have been connected to otherwise. And that's just a product of us having the time to build a rapport with a patient and also asking a comprehensive social determinants of health survey to all of our patients before the intervention. Through those mechanisms, we often catch things that would have fallen through the cracks otherwise. And I would say that we are most successful in helping medium risk patients. A lot of high risk patients already are getting those programs referred to them by their physicians. And of course, our low risk patients don't need them as much. But those medium risk patients are kind of where we can really bridge the gap. And so yes, LCS teach skills like wellness skills and opioid education that can be used across the lifespan. But the position has also grown into a type of gap filler for the entire hospital experience. And that's what makes it kind of a novel approach to thinking about pain.
That's very interesting. The next question is, does the pain management technique you use differ according to the level of injury?
So depending on the injury, we have a wide range of techniques that can be used. Most of the skills, though, are focused on nervous system regulation. So they don't primarily focus on the injured area, but we are able to kind of change our intervention methods to match whatever the patient needs, whatever their situation is, whatever their injury is. But a lot of it is more verbal communication, so it doesn't really rely on working with the injured area.
And we're able to not work with an injured area as well. So a lot of our skills are really adaptable. So if a patient is on bed rest and something is a little bit more physical, we can just ask them, we can explain it to them and invite them to do it later on when their healing is further down the road. But we don't do it with them in that inpatient setting.
Could you maybe give us an example of some of the techniques that you use?
Mm-hmm.
Yeah, so one of them is called progressive muscle relaxation, which we love to use and patients really respond well to it. And it's kind of tightening and relaxing different muscles throughout the body. So we notice like this is really good when patients have an external fixator, showing them that they can relax other parts of their body. It's been super helpful for a lot of patients I've worked with.
And a lot of them are dealing with sleep issues and just general discomfort throughout their entire body from being in a hospital bed for up to a month, sometimes more. And so these techniques, like progressive muscle relaxation, for instance, can kind of shift their attention to the more positive sensations that their body can have and away from the injured area. The other techniques that we use are part of the community resiliency model, which was developed by the Trauma Resource Institute and is a set of 6 wellness skills. And so those are kind of our main techniques in our toolkit, but we also do reflective listening and motivational interviewing with patients to kind of increase that rapport and learn more about their situation.
Yeah, that's really great. That sounds really cool. So what does success look like for this program? What are the metrics, outcomes, or stories you are looking for to define success?
So this is a hard question because on a day-to-day basis, success for me is positive feedback from a patient. That feeling of walking into a room where a patient has anxiety and walking out knowing that they have skills to deal with that. That is success to me, and being able to give them that skill set is so rewarding. I consider a day successful also when a patient in follow-up reports to me that they have been using the skills away, like after we teach them, or that they are no longer taking opioids. That being said, we do have more quantitative outcomes we're looking for. We are in the pilot phase of a research study, and we are launching a randomized control variation next month. And so that we are looking at a number of quantitative outcomes, including reduced morphine equivalencies for inpatient and outpatient opioid use. One thing that we've done that's exciting is we have developed an SMS tracker. And so when our patients leave the hospital, they get a text to ask about their opioid usage every day. And they report to us how many pills they've taken. And in our pilot run of the tracker, we had very high compliance. And so this will allow us to collect data about patient opioid usage that wouldn't otherwise be known. Another measure that I have personally for success is in the number of referrals we can give. Like I was saying earlier, that is a huge part of our role that is kind of grew organically. And nothing brings me personally more satisfaction than helping a food insecure patient get access to healthy meals after discharge, or making sure that someone who has an amputation gets, connected to a group or some type of resource to help with that experience, because that is clearly life transforming. And oftentimes patients are leaving the hospital without any resources for that. So one of the benefits of our role is that we get lots of face-to-face time with patients. So over an inpatient stay and follow-up visits, we might spend up to 4 hours, sometimes more, with each patient. And that's a huge amount of time compared to other healthcare professionals. And it's definitely enough time to kind of build a face recognition and relationship with the patient. And to me, that's kind of the most important part of our role, and that is what success looks like. When I walk into a room in the clinic and a patient recognizes me and is happy to see me, that's success. And of course, those quantitative outcomes are important as well, but those day-to-day stories and experiences are really what makes it worth it.
Yeah, that's great. Thanks for sharing that.
I have a question. How can we increase the conversations around non-pharmaceutical strategies of pain control and help educate more people?
So we can be more intentional about the conversations happening around pain management. One of the biggest hurdles that we face on a patient basis is setting expectations for their pain, and having them understand what that is going to feel like and be like. And we can be better communicators about pain as healthcare professionals, what to expect, why we experience it, etc. But we can also be intentional about researching and funding behavioral interventions for pain. Like I mentioned before, a lot of the research being done is on the pharmaceutical side, like developing an alternative. And most of the research on behavioral interventions is happening on the treatment side rather than on the prevention side. So how can we use behavioral interventions in a treatment setting, or with people who are in recovery, and not so much on this preventative side. And so amplifying this behavioral research is really important to LCS expanding our toolkit, and also for the general public to understand that there is alternative to opioid use. And then I would add to that also just education for physicians and for healthcare professionals, because a lot of them don't have any formalized training on like the opioid epidemic. And when our physicians understand it and can communicate to us as patients, we are better advocates in our communities also for lessened opioid use. Yeah.
Yeah, I think that's a really great point. All right, at this time, we would like to open the conversation up to any questions that the audience has related to the life care specialist position and preventing opioid misuse through pain coaching. Ashley, do we have any questions at this time?
Yes, we actually have two questions, and please feel free to continue to leave your questions in the chat or comments. The first question for you, Lauren and Bailey, are you using EMDR and other bilateral therapies?
So we are not. Our kind of goal as LCS is to stay the most up to date on cutting edge pain management technologies and innovations, behavioral and pharmaceutical. And kind of initially we had to kind of limit what that toolkit would look like for the purpose of a randomized control trial, to make sure there aren't any confounding variables. But in the future, when this position has expanded, we definitely want to expand and look at other pain management strategies. I know that there's so much research coming out about lots of different things. Like I mentioned before, the Vibracool and Fuzzy, the plant-based pharmaceutical. I mean, there's so much happening in this realm. And we just kind of had to like take a more limited subset of techniques to start.
That makes sense. I definitely get that. The next question in the chat is, can you please explain the difference between high, medium, and low risk patients?
Yeah, so we, with each patient, we use the opioid risk tool that has a couple questions on it for the patient to answer. It has to do with personal history of substance misuse, any family members, mental illness, and a few other questions that kind of analyzes if they're at risk, and it determines, depending on how many yeses they answer, they get a score. And so There's a low score, a medium score, and then the high risk. So the more that they answer yes, the higher the score is.
And so that's kind of how we group patients in terms of opioid risk. That's a validated measure, the opioid risk tool, but we also, once we kind of do that comprehensive social determinants, we note which patients might fall into that were not kind of caught by that tool. So it's mostly the opioid risk tool, but with kind of the discretion of the life care specialist as well.
Yeah, we use a combination of a couple other surveys. Also what the patients tell us, we'll take a note of what they have to say or what their concerns might be. And that's another way how we kind of analyze what level of risk.
Okay. And I'm sure you all are always assessing your tools and making updates and changes over time.
All the time. Always changing. It's a good thing, staying up to date.
Yeah, and as we get more resources in the hospital for, we're getting new homelessness resources. We're getting new resources for amputees. We're getting new. So as those things evolve as well, we're able to do more and more for patients. And that's exciting to us.
Awesome. We have more questions. So the next question, do you also see the application of LCS interventions in other medical specialties?
We definitely do. Our goal, we started in orthopedics, but our goal is to kind of be in every area. We see LCS in treatment facilities and in the different clinic settings.
Some other areas we're talking about expanding to are like OB and sickle cell. And so, there's so many places where patients are dealing with pain, burn, and so many different, chronic pain versus acute pain. There's so many kinds of complicators in that, but we're ready to take it on. And we think that the LCS could be utilized all over the hospital setting, but also in more outpatient settings, like in doctor's offices and clinics. So yeah.
And not only just for like the pain management side, LCS, really a big part of our job is also like the emotional support. So when you're in a hospital, so much comes up, as you can assume, after having an injury or being alone there for whatever reason. And so another big part of our job is being there to support them emotionally, talking through setting expectations of what's going to happen, explaining the procedure before it occurs. So LCS really could be utilized in a lot of different healthcare situations.
And what's so exciting about where we're at is that we are in kind of this, we're evolving every day, and we are getting such amazing feedback from the community, but also the physicians we work with that will help us improve and expand in the coming years and months.
I think that's such a great segue to the next question in the chat. The question is, how has your experience with fellow healthcare professionals been in the healthcare setting so far in caring for patients?
To be honest, it's something that we were nervous about going in. We didn't want to step on any toes, and we wanted to kind of fit into this already existing model. And we have been welcomed with open arms. Physicians ask us to see their patients, nurses ask us to see their patients, techs refer patients to us. And in this next version of our trial, we aren't going to have as much discretion about who we see, but it has been really rewarding for physicians and nurses and existing healthcare professionals to realize what we do and kind of know when to ask for our help. And that has, we've kind of fit in seamlessly, and that isn't necessarily something we expected. Yeah. We knew we were kind of coming into an environment that had a very set way of doing things. And of course, we tried to be as gracious as possible, but we were welcomed with open arms.
We also have like an amazing team. I will say that we work with at Grady. We got very, very lucky to get to work with them.
Yeah, the orthopedic Emory at Grady team has just championed us the whole way through. So
That's so amazing to have support like that. And I'm sure it makes the job that much easier to kind of go into these healthcare systems and implement something new. One person put in the chat that they really wish that this was available for them because they were dealing with constant pain and all they knew was pain pills. And they felt like this position is so needed. So kudos to you all. Also, there's a question about is there a way that to learn more about this position? How, if someone's interested in talking to their doctor about the LCS position, what should they say? What resources can they give their doctor?
So I would invite you to connect with us on our website, which is cwc.ngo. And there's a lot of information there and a contact form to get even more information about the Life Care Specialist program. And we will also be sharing, I think, a free app that you can use that teaches the skills of the model that we teach. It's called iChill. And you can find it online at ichillapp.com, or you can just search in the App Store. And that goes through that core community resiliency model that we teach. And so if you want to learn more for a personal, pain management strategies, I would definitely go there first. And if you want to learn more about the life care specialist position, I would invite you to go to our website and to follow us at Christopher Wolf Crusade on Instagram, Facebook, LinkedIn, and TikTok.
Oh, you guys are cool. Y'all are on TikTok? Wow. Excellent. I'm just scanning the chat one last time to see if I've missed any questions or comments. It looks like we've covered them all. Alicia, I'm going to hand it back to you.
All right. Since we have some time, I did have another question. I was just wondering how the COVID-19 pandemic has impacted your work.
Yeah, so I guess the largest impact with COVID has been that patients can't have visitors, and that's a huge change. We worked with one patient, actually several different not so fun situations, but one specifically was having an amputation and could not have family or friends there to help support her in that life-altering experience. And so life care specialists, the advantage we had is we got to be in the hospital. We got to go and support a patient like her and other patients. We bring blankets. We stop by multiple times a day and kind of get to act as that family member or friend, seeing what they need.
Sometimes helping them communicate with family members too. So some of them ended up in the hospital without a phone or anything like that. And so helping them write to their family member, or we had a patient, he drew a picture for his wife and we gave it to her. So having them kind of helping patients kind of connect with their family members when they can't physically be present as well. And that's something we did not expect. I started after COVID and Bailey started before, so she has more of a view on that.
Sorry, no, go ahead.
I was just gonna say, I think that's really cool that you get to kind of fill that position at this time.
I think that's been the best part of our job, I guess, the past year is getting to do that for patients. Because I can't imagine being in a hospital and not having my family member there with me. So we're grateful in that sense.
And some of them, I mean, truly, some of our patients are there for up to a month or sometimes longer. And after pain, the number one complaint we get is boredom. And so just having a familiar face come say hi every day is really helpful. It means more to them sometimes than even the skills we can teach. And that has been really powerful for us to realize too.
Yeah, that's really great.
Alicia, let's see if we can squeeze in one last question from the chat box. This person would like to know, is the program only available at Grady? And I'm going to tack on a second question. Are there plans to expand the program?
Absolutely. So it is only available at Grady right now. We're in a pilot, and we're kind of locked into a 1-year research study to kind of demonstrate the efficacy of the position. But we have every plan to expand. Eventually, we hope that this is in every hospital, every healthcare setting where it could be in the United States. And who knows how long that will take. You know, we're moving very quickly right now, but we are so excited about all the traction that we're getting, and there is so much momentum behind this. That question that just we get that question every day from someone who wants a life care specialist, but we're trying to make sure that we kind of have this insular setting at Grady that has been so welcoming, and getting all the details ironed out before we expand further.
Wow, that just shows how needed you all are. So,
Yeah.
Okay, that was the last question from the chat, Alicia.
All right. Well, thanks to everyone who's joined this conversation today. And I would like to say a special thanks to my co-facilitator, Mary, and the Georgia Public Health Association Emory chapter, as well as to Lauren and Bailey and the Christopher Wolf Crusade. We will be hosting another Facebook Live conversation next month on April 14th, so make sure to like our iPrice page and look out for more information about that event coming soon. Mary, would you like to let everyone know how they can connect with the Georgia Public Health Association?
Yes, so they can connect with the Georgia Public Health Association Emory chapter on our Facebook. You can just type in Georgia Public Health Association dash Emory chapter. And then on Instagram, we are gpha.rsph on Instagram.
Awesome, thank you. And that's all for today, so thanks everyone.
Thank you.